Well, ladies and gentlemen, both of these lecturers gave a very perfect demonstration of the profit and benefits of their method. So it's not my task to go in every detail of their presentations and to give an estimate which one is better for the total application. So I will discuss one special topic, both of them treated. And this is the demonstration of the penumbra by their method. Well, I have to tell you that the penumbra is an experimental model. If you decrease the flow below a certain limit, where is it, the pointer? Then you get electrical function failure, and if you go further down, you get release of potassium, indicating the damage of the membrane, and therefore the irreversible damage of the tissue. And this is, as it was done in baboons, the center is the irreversible damage, and surrounding is the penumbra, which can be revived if the reperfusion is valid. If you want to transfer this concept into humans, you have to use a method which can measure the perfusion in the tissue and the metabolism in the tissue, indicating if the tissue is dead or not. And this can only be done by positron emission tomography. You can measure cerebral blood flow, indicating the defect from the ischemia. You can measure cerebral metabolic rate of oxygen, indicating if the tissue is still alive or not. And what you see here is the difference. For instance, in this region, where you have persistent oxygen metabolism, but no blood flow, and therefore increased oxygen extraction fraction, indicating that this tissue is still alive despite the flow is very low, and this is the penumbra. In other areas, I'm sorry, the pointer is not working anymore. In other areas, you have also persistent glucose consumption as down here, but no oxygen consumption as shown up here. And this is an area where the metabolism is disturbed. Due to the defect in oxygen metabolism, you get anaerobic glycolysis and lactate production, and this tissue is also dying over time. So if you want to transfer, later on you see the effect here, and you see that this tissue is surviving where the oxygen metabolism was preserved, and this tissue is dying where the oxygen was low and lactate production was there. So if you want to transfer that now into the methods you were presented before my talk, you only use or mainly use the perfusion in the vessels. It's not the tissue blood flow, because perfusion-weighted imaging and perfusion CT only measures the intravascular compound of the tracer and not the tissue blood flow. And this is a big difference. So you want to define oligemia, you want to define the penumbra, and you want to define the infarct score. What we have done is a comparison, because you have to validate methods before you apply them in humans. And what we compared, for instance, first for the mismatch in the MR, you have time to peak and the diffusion-weighted imaging. Actually, diffusion-weighted imaging is an indication of the intercellular movement of water molecules. So this is a tissue compartment, and therefore it's a little bit closer to the reality. And then we compare that to the cerebral blood flow, the oxygen metabolism, and oxygen extraction fraction. By the increase in oxygen extraction fraction, you demonstrate the penumbra, because this is tissue which is still alive and can survive if you reperfuse. Then the first thing is to indicate if there is irreversible damage of the tissue. And for that you use diffusion-weighted imaging. Diffusion-weighted imaging corresponds quite well to the size of the defect in oxygen metabolism, indicating irreversible damage. And you see that in this lower graph, the pointer in this. There's a good correlation between these two volumes. However, there are several areas which might be reversible diffusion-weighted imaging. That means that also in the beginning, the diffusion-weighted imaging is not a clear indication of irreversible damage. And you see that in the lower slice here, this is where the flumacenil was still intact, indicating that the tissue was still alive, but there was diffusion-weighted imaging lesion, but with later on, this tissue completely recovered without any treatment. what you see here is that both indicated about 84 to 83% of the infarcted tissue, but the non-infarcted tissue, oh, very good, thank you, sorry. Yeah. But the non-infarcted tissue, as you see here, was never predicted by the PET imaging, but in 25%, the diffusion-weighted imaging lesion was reversible. That means that this tissue was not infarcted. Oops, but now the movement is not working. We have problems with this trace also. So if you now go to the perfusion-weighted imaging as an indicator of, yeah, but it doesn't move. Right. Yeah, the slide doesn't move. No, it doesn't.
Sorry.
And this one? Okay. So what we did is now to test the perfusion-weighted imaging delay in 2, 4, 6, 8, and 10 minutes, and you see that 4 and 6 minutes are a good indication of the blood flow. If the blood flow is defined as a penumbra blood flow of below 20 milliliters per 100 gram per minute. And these are a few examples where we have a good fit up here, where the fit was not so good, as shown here, and here the fit was very bad. You see a large defect in time to peak in the perfusion-weighted imaging, but a very small defect in the PET imaging. And this is now the problem to discriminate between non-harmful oligemia and potentially harmful penumbra flow. And this one you must do. And what you see here is that the correlation between the blood flow as measured by PET and the blood flow as estimated by perfusion-weighted imaging is quite poor. It's quite okay in the middle range, but it's very bad in the lower and the upper range. If you now define the penumbra by the difference of the perfusion to diffusion-weighted imaging as indicated in the lower part of the slide. What are you doing now? No, it's working. Okay, fine, thanks. Now we get the perfect one. So in this one you have the perfusion-weighted imaging defect indication and the perfusion-weighted imaging penumbra indication by multimodal MRI compared to the CBF, CMAO2 and an oxygen extraction fraction for the definition of the penumbra. So we define the penumbra as the decrease of oxygen extraction fraction as shown here. And what you see now is in some instances you have a very good correspondence between these two as shown in the lower one, and in some instances the correspondence is very poor. You see a lesion perfusion-weighted imaging, but this is not penumbra. And if you compare now the cases we have investigated in the first hours of the stroke, all these cases had a perfusion-weighted imaging indication of mismatch, but not all of the cases also had a penumbra as defined by the positron emission tomography. And in addition, diffusion-weighted imaging lesion reflects impaired tissue integrity. There are some false positives. Oligemia is not at risk, and the mismatch contains areas with varying oxygen extraction fraction values, indicating this is not the same as the penumbra. So usually the mismatch overestimates the penumbra, and you have to be very careful and validate your measure on a quantitative measurement. We have done now recently the same with perfusion CT parameters. In perfusion CT, the problem is even bigger because you only use intravascular criteria for definition of your damage in the tissue. The tissue is the important thing, not the vessel. The vessel, of course, is important for the decision. So what you do is calculate CTP, CBF, CBV, MTT, Tmax, TTP, and you see these different parameters give different responses to one response in the PET, which is a quantitative measurement, and you can have individual regional measurements for all these parameters. So the correlation between PET CBF and the CT perfusion parameters is indicated here. It's a good predictor, but it's not absolute, and you can find that some of these areas are quite good. So Tmax is quite good, time to peak is quite good, the others are not as good, as also indicated here. So these give you a quite good correlation between perfusion CT, the estimates of the perfusion, and the PET estimates of the perfusion values. The problem is much bigger to define irreversible damage. And it depends also on the size of the infarct, as demonstrated very early by Wintermark. If the infarct is very small, then the limit is at 2 times the cerebral blood volume of 2, and if the lesion is very large, the threshold is at 2.3 percent cerebral blood volume, and this is different also to think about. There you see the correlation between CBF, CBV, and diffusion-weighted imaging, and the absolute value of 15 and the absolute value of 1.8 milliliters per 100 gram per minute for the prediction of the irreversible damage. We also have done a few studies comparing the perfusion and the damage of the tissue as indicated on the PET, as shown here as a flow value below 12 milliliters, and the correlation to the blood volume as indicated here might be positive, but we have to analyze this data more carefully and validate these effects carefully. So in conclusion, Tmax, TTP, and CBF perfusion best in detecting the penumbra flow thresholds. Tmax and CBF did not perform significantly better than the easy-to-obtain non-deconvoluted parameters of TTP. Regarding the current evidence, it might be justified to use simple TTP maps for clinical decisions in acute stroke setting. Further work is needed to correct for the CTP individual variability of the best cut thresholds, especially for the threshold of irreversible damage for the cerebral blood volume. And this definition of the irreversible damage, in fact, is still a problem. What should you use, CBV or CBF, as determined by CTP? So in conclusion, in my opinion, for the definition of a penumbra, the mismatch concept is still a little bit better as defined by MRI parameters, because you have at least a quite relevant marker for irreversible damage, while the marker for irreversible damage in the for the CT perfusion changes is very vague and has to be validated. For the perfusion data, I think you have to validate your values and use appropriate values to have a good definition of penumbra flow in correspondence to oligemia. Thank you very much.